Okay, so let's go from PID to sharing decisions.
Okay.
We're just bouncing all over the place with these articles. There's like no theme here at all this year. We're going to talk about shared decision making. The title of this is Shared Decision Making in the Emergency Department, Respecting Patient Autonomy When Seconds Count. It sounds so dramatic. In the Academic Emergency Medicine, July of 2015.
I have to say, though, I love titles like this.
I do too.
You know, like
it sounds so dramatic.
shared decision making doesn't grab me, but when seconds count, what? Do seconds count?
There they gotcha. So this is the hot topic, right? It's in everything. SDM,
it's a big
shared
deal.
decision making. It's in everything. And this article gets into some theory that's probably a little more than we really need to get into. But it brings up some concepts that honestly we could boil this down to like one sentence. But we'll go through this because I'm sure the questions will come out of this article. So the whole idea of shared decision making is it's collaboration. You actually talk to someone and listen to what they have to say. Kind of a shocking concept.
Imagine that.
Imagine that. And you throw in there some science. So you throw in some information on what we know best right now about whatever the situation is. And then we all sit down together and figure this together. It's considered really the optimal way to decide things. And if you look at the history of how we've decided things in medicine, we've been paternalistic for a really long time. And in fact, even as recently as Osler's time, back about 100 years ago, it was felt to be harmful to tell people all the details about their health care because they might be depressed or they might not heal well, or we've gone a big spectrum of sort of how we approach this stuff. For us in the emergency department, we have, as always, everything is uniquely challenging in the ER. Have you noticed that? Everything is uniquely challenging. So yes, it is a uniquely challenging setting. But that being said, it doesn't mean we can't do this. We just have to take the time to do this. So we can, and we do frequently. We do a lot in things like antibiotic use, et cetera. We use this quite a bit. This paper goes into a conceptual model for how to do this. I will give you some of that. I don't want to kill you with this stuff, but this is things they might ask questions on. A lot of this is quite logical, but they try to sort of conceptualize this, so we'll get into this. The concept overall, and I kind of like this, nothing about me without me. So don't you do anything about me without me being involved. And I like that. That's kind of has a nice rhythm to it, and it is a good sort of way of approaching the concept. What a patient wants is safe, high-quality care. Okay, they want, from their perspective, my view of this, I want it safe, I want high quality, and I want to have a say in this because it affects me. And there's a thing called the Picker Institute that basically deals with these concepts, and they came up with this idea of shared decision making. And what it does is factors in several very important characteristics of care. I think there are a total of 8 or 9 of these. One is to respect the patient. What they want, what they value, what they say their needs are. Respect that.
That's important.
Very
like
important.
To understand that's important.
Yes, like not say it's just I'm your doctor, I say so, to actually respect that. To coordinate and integrate care. So another huge important characteristic of care is to coordinate care, which I have to tell you, system-wise in general in the United States, we're terrible at that. Information, communication, and education, that you actually effectively communicate what we know and educate patients about what's happening in their health care. Making sure patients are comfortable. So making sure they have pain management, they're physically comfortable when we're sort of dealing with their health care and the decisions we have to make, and that they're emotionally supported, and that we take away any fear we can. You can't take away all of it, of course, but do the best that we can and if you can do that, people do get better faster too. So it's worth it on lots of different levels. Involve the peripherals. So if patients have friends and family that they want involved, honestly, often they want them more than they want you. So get the family and friends involved. The family and close friends are very helpful in decision making if the patient wants them there. HIPAA is a whole separate issue. That's the law. This is just being logical and helpful to an individual patient. Not only coordinating care, but continuity of care. This is where our hospitalist system breaks this down, where you are sure that whatever is happening with the patient travels with the patient instead of with the provider. It doesn't really work that way as well as it should, and we really want to make sure the patients have access to this information. Actually, in LA County, we're going sort of patient access to their own health care, all their health records online as of like 2 days from now or 2 days ago, recently. They need to have timely access to care. This is something that in the healthcare system to be optimal characteristic of care is if you need something, you get it, and you get it in a timely fashion. And it shouldn't have to be where it disrupts your life. Well, I'm sorry, the only appointment we have for your broken ankle is 2 weeks from Thursday at 2, and you happen to have something scheduled that day. It's supposed to keep the patient as a priority in the system, not you as the provider. And all this makes really good sense. The Institute of Medicine, which we talked about before with errors, they actually have addressed this idea of let's make quality better, not in this whole system issue, but part of that includes this shared decision-making concept, not just continuity of care, blah, blah, blah. It's getting the patients involved in their healthcare and in the decisions, both from our offering it up and their actually offering it back. The American Academy, the Academic Emergency Medicine Group, they have a consensus conference that they do, and every year they pick a topic. In 2011, their topic was basically interventions to help quality in medical care and emergency medicine, and they talked about this. The shared decision-making actually is a really good area for research to see what helps. The evidence does suggest what research we have is that having patients involved in their decision-making is helpful. They get better faster, they understand their disease better, and they're more satisfied, and there's nothing to say that it's bad. So far the preponderance of what we know is it's good and it isn't bad. So, if it's good but it also can cause some harm, then that's a problem. So far it doesn't. And so there's some research that says this is something we should be doing for a lot of different reasons. Now we, the deliverers of all of this, have reported some barriers, and it's not surprising. And some of the quotes that are out there, well, patients prefer the physician to decide. That's that paternalistic thing, and I think honestly most patients don't, and in fact the research says most patients don't. Patients will opt for more aggressive care if they know all the choices that are offered. Well,
that's
actually,
true, yeah.
that turns out not to be true. When they really understand the differences and the sort of risk benefits of all of it, they don't necessarily opt for more aggressive care by any means. And in fact, cancer care is one area where this is particularly profound, where it's opt out sometimes when they're given the chance to opt out. Another thing that we'll often say is it's too complicated. Oh, yeah, it's too complicated.
They couldn't understand
They could never understand this and then make a choice. How could we offer this to them?
They didn't go to medical school.
It's not our decision whether it's too complicated. It's our decision to educate. That's our role. So all of this, even though we say that there are problems, about 60% of us do say we use shared decision making. So even though we beef about it, we do this. What they talk about in this paper is a model. Now, I don't want to drag you through this model. I'll talk about some of the highlights of this model, but it's a thing called the Charles model that they've developed by Charles et al. That deals with sort of how to do this. And this was devised not in the emergency department. This was devised in breast cancer patients. This is where this initially started. And the concepts that are involved in it, if you think about it, I have a positive mammogram and I need to make some big decisions. The concept of this that fit with both breast cancer developing this thing and what we do in the emergency department are things like you get one shot at a decision. So I get to decide mastectomy or not if it's breast cancer. And I can't go back and say, oh, we'll put it back. And in the emergency department, it's the same thing. It's a one decision deal, not infrequently. We're going to give you thrombolytics for your stroke or not, right? It's a one decision deal. It's early in the course of something. It has to be now. Okay, it can't be tomorrow. We fix it now or we don't have this option anymore. And there are often significant trade-offs. It's not like everyone agrees that this is the best thing ever and there's no downside. There are often trade-offs. So these concepts that were developed in a doctor's office dealing with a breast cancer patient really do translate pretty well to us in the emergency department. They just are telescoped. They're done super fast instead of over weeks to months where you have some time to make a decision. It involves lots of outcomes, uncertainty of choices, and positive and negative effects that affect the patient, not us. So they have to be involved in this. So that's where the shared decision-making power comes in dealing with this. The paternalistic model, which was around forever and a day, basically assumes that there's one best answer. And there just isn't. In most things, there isn't one best answer. So that's where this involvement is really key. And the trade-offs have to be sort of offered because we don't live with the outcome. Yeah. The patient lives with the outcome. So they're the ones best able to say, this works with my life, this doesn't work with my life.
They should know what the options
are. And they should know the options for us to say, we decide for you. And when they look at whether we can decide, we're wrong. Often when we think we know what the patient's going to say, we're completely wrong.
Yeah.
So getting them involved is an important sort of concept to do. Now, in the article, they have this little table with little arrows, and this goes to this, and this goes to his. This is an incredibly logical concept of the first part is you go to the patient and you say, here's some information. Here are the options we have. Here's the risk. Here's the benefit. Here's the information. You lead that. The patient assimilates that information. You make sure that they understand. Then you talk about it. The patient says, well, I don't want surgery. I'd rather have antibiotics for my appendicitis. And you say, well, that's fine. You'll still need it 25% of the time, but that's an option. You talk for a while, and then the patient says, okay, now here's what I want. I want antibiotics instead. I understand I have a 25% chance of this failing. That's what I want. And then you say, great, and you move on as the provider. So this is a very linear, logical, with a lot of sort of chatting in between, go back and forth, that happens to make the shared decision-making work. And it's completely logical stuff. So you provide information, you talk about it, they say what they like, you make sure that you all agree, and you move on. It helps to actually also have family members involved in this if they're involved and they want to be part of it. Again, I mentioned this was initially for women with breast cancer, but it is definitely something that we can use in the emergency department. Now, in the article, at this point in the article, they go through 3 clinical case scenarios. And it's something that it's helpful to kind of, if you don't get the concept, which I think most of us do, but if it's something you're having some trouble grappling with on different levels of acuity, it goes through 3 cases that are probably worth taking a read, but we're not going to take you through it here because the model and the concepts I think are clear, and the kinds of things they might ask on.
And they're not going to test you on the
details
of the cases.
No, it just is more illustrative to help you. So there is, though, a table that I did not duplicate on the slides, or we're not going to duplicate here, that deal with factors that can influence either a patient or you or a system, can affect how shared decision making works. I don't know if that's something they would dig into for a question. So this is an area where I can't guarantee that the slides or what we're discussing here will cover absolutely everything out of this article they might ask, because this table is exhaustive and just not worth putting down on this for you. It's just, most of it's quite logical, so I think you could logic your way through most of it. So if we're going to summarize this particular article, so this is the cut to the chase, take-home points. Shared decision-making is a collaboration between you and the patient and their family. It requires sharing medical information and the patient sharing their preferences, and it's really considered very vital in patient interactions. There are some characteristics that will maximize our care for patients, not necessarily just shared decision-making, but just care in general. And research says that shared decision-making itself is very helpful in patients as far as how their outcomes and how they look at their care. We are not very good at figuring out what they want.
Right.
They need to tell us
There
what they
have been
want.
studies about, whether we think somebody wants antibiotics or not.
Right.
They ask the doctor, did you think they wanted the antibiotics?
Yeah.
Then you ask the person, and they're like, I didn't want antibiotics.
Exactly.
So we're
but
just
you
not good at
assumed
knowing.
it.
Well, we make
and
assumptions.
We're wrong. And we're
Yes.
wrong. Exactly. And even though we think that there are barriers to doing this whole shared decision-making thing, we do it, actually.
Yeah.
60% of the time, we say we do it. So we do this. So that's shared decision-making. Interesting concept, really hot topic, kind of logical stuff in there, and I have no idea what questions I'll ask.
I'm going to guess that the questions are, like you said, you can kind of logic your way through them. I think that if you understand this basic principle that this is important to consider what the patient, there should be 2 ways, and they should have, I think that they're probably pretty straightforward.
Just think of it as your personal relationship with your significant other, and then there you have it. You have to talk.
Depends on your relationship.
I guess it does.